Public health sciences, communication skills. Patient-centered interviewing techniques. Introduction. Introduce yourself and ask the patient their name and how they would like to be addressed. Always address the patient by the name and pronouns they provide, and avoid making gender assumptions. Sit at eye level, near the patient, while facing them directly. Agenda setting. Identify concerns and set goals by developing a joint agenda between you and the patient. Reflection. Actively listen and synthesize the information offered by the patient, especially with respect to their primary concerns. Validation. Legitimize or affirm the patient's perspectives. Recapitulation. Summarize what the patient has said so far to ensure correct interpretation. Facilitation. Encourage the patient to speak freely without guiding their responses or leading questions. And remember to allow the patient to ask questions throughout the encounter. Establishing rapport, and here's a mnemonic, PEARLS. Partnership. Work together with the patient to identify their primary concerns and develop preferred solutions. Empathy. Acknowledge the emotions the patient displays and demonstrate understanding of why they are feeling that way. Apology. Take personal responsibility when appropriate. Respect. Commend the patient for coming in to discuss a problem, for pushing through challenging circumstances, for keeping a positive attitude, or for other constructive behaviors. Legitimization. Assure the patient that their emotional responses are understandable or common. Support. Reassure the patient that you will work together through difficult times and offer appropriate resources. Delivering bad news. And here the framework is spikes. Setting. Offer an advance for the patient to bring support. Eliminate distractions, ensure privacy, and sit down with the patient to talk. Perception. Determine the patient's understanding and expectations of a situation. Invitation. Obtain the patient's permission to disclose the news and clarify what level of detail they would like. Knowledge. Share the information in small pieces without medical jargon and allow time for the patient to process. Then, assess the patient's understanding. Emotions. Acknowledge the patient's emotions and give them the opportunity to express those feelings. Listen closely and offer empathetic responses. Strategy. If the patient feels ready, discuss treatment options and goals of care. Offer an agenda for the next appointment. Giving control to the patient may be empowering, so ask how they feel a problem might be solved and what they would like to do about the plan of action. Gender and sexuality inclusive history taking. Avoid making assumptions about sexual orientation, gender identity, gender expression, and behavior. For example, a patient who identifies as heterosexual may still engage in same-sex sexual activity. Use gender-neutral terms when referring to the patient or the patient's family. For example, say partner rather than husband or wife, at least on first meeting, until the patient instructs otherwise or uses specific pronouns. Remember, a patient's assigned sex at birth and their gender identity may differ. Do not bring up gender or sexuality if it is not relevant to the visit. For example, if a gender nonconforming patient seeks care for a hand laceration. Consider also stating what pronouns you use when introducing yourself, such as, "I'm Dr. Smith," and "I use she/her pronouns," and then asking patients how they would like to be addressed. Think of other inclusive practices too, like ensuring the correct name and pronouns are recorded in the electronic medical record. Reassure patients about the confidentiality of their visits, and be sensitive to the fact that they may not be open about their sexual orientation or gender identity to others in their life. And remember, trust is built over time. Listening to and learning from patients about how they would like to approach these topics is key. Cultural formulation interview. Here the focus is to identify the problem through the patient's own perspective. Ask the patient to describe the problem in their own words, or how they would describe it to their family and friends. Identify cultural perceptions of what led to the problem. ask the patient to explain why they think they are experiencing it. Next, identify how the patient's background influences the problem. Ask them what makes it better or worse, and investigate the roles of family, community, and spirituality. Then, identify how culture may impact current and future interventions. Ask if the patient has concerns or suggestions about the current treatment plan. If they do not want to follow medical advice, explore whether their preferred approach can be combined with the standard regimen. Finally, identify possible barriers to care based on culture. Ask if there is anything that would prevent them from seeking care in a standard medical institution. Probe for explanations and ask what might increase the chance of maintaining a strong patient-physician relationship. Motivational interviewing. This is a counseling technique to facilitate behavior modification by helping patients resolve ambivalence about change. It is useful for many conditions, such as nicotine dependence or obesity. Motivational interviewing is especially helpful when a patient has some desire to change, but is not yet fully committed. It may involve asking patients to examine how their behavior interferes with their life or why they might want to change it. It's also important to assess barriers, like food access or untreated trauma, that may make change more difficult. Another key element is assessing the patient's readiness for change, because this helps guide physician-suggested goals. These goals should be SMART, specific, measurable, achievable, relevant, and time-bound. Trauma-informed care. Patients with a history of psychological trauma should receive thorough behavioral health screenings. This means regularly assessing mood, substance use, social supports, and suicide risk. Assessments should focus on trauma-related symptoms that interfere with social or occupational function. Always be empathetic. Do not ask invasive questions that require the patient to describe trauma in detail. Ask permission before discussing trauma-related topics. Before starting a physical exam, reassure patients that they may signal to end it immediately if they feel too much physical or emotional discomfort. Offer the presence of additional staff for support if they wish. Psychological counseling may be indicated, and follow-up counseling should be offered or advised when appropriate. And remember the 4 R's of trauma-informed care: realize, recognize, respond, and resist re-traumatization. Challenging patient and ethical scenarios. The most appropriate response in these situations is usually one that is patient-centered, open-ended, and empathetic. It should acknowledge obstacles in care and validate emotions. Very often, it also honors one or more of the 4 principles of medical ethics: autonomy, beneficence, non-maleficence, and justice. Appropriate responses are respectful both of patients and of other members of the healthcare team. Always consider the patient's point of view. Situation: patient does not follow the medical plan. Appropriate response: determine whether there are financial, logistical, or other obstacles preventing the patient's adherence. Do not coerce the patient into adhering, and do not refer the patient to another physician. Instead, schedule regular follow-up visits to track the patient's progress. Situation: patient desires an unnecessary procedure. Appropriate response: attempt to understand why the patient wants the procedure and address the underlying concerns. Do not refuse to see the patient, and do not refer the patient elsewhere. But avoid performing unnecessary procedures. Situation: patient has difficulty taking medications. Appropriate response: determine what factors are involved in the difficulty. If comprehension or memory are issues, use supportive techniques such as providing written instructions, using the teach-back method, or simplifying the treatment regimen. Situation: family members ask for information about the patient's prognosis. Appropriate response: avoid discussing issues with relatives unless the patient has given permission. Situation: a patient's family member asks you not to disclose the results of a test if the prognosis is poor, because the patient will be unable to handle it. Appropriate response: Explore why the family member believes this would be detrimental, including whether there are cultural factors. Explain that if the patient wishes to know information concerning their care, it cannot be withheld. However, if you believe the patient might seriously harm themselves or others if informed, you may invoke therapeutic privilege and withhold the information. Situation: a 17-year-old is pregnant and requests an abortion. Appropriate response: many states require parental notification or consent for minors seeking abortion. Unless there are specific medical risks associated with pregnancy, the physician should not sway the patient's decision for or against elective abortion, regardless of the patient's age or fetal condition. Discuss options for terminating the pregnancy and refer to abortion care if needed. Situation: a 15-year-old is pregnant and wants to raise the child, but the patient's parents want you to tell her to give the child up for adoption. Appropriate response: the patient retains the right to make decisions regarding the child, even if her parents disagree. Provide the teenager with information about the practical aspects of caring for a baby. Discuss options for terminating the pregnancy if she requests. Encourage discussion between the patient and her parents to help them reach the best decision. Situation: a terminally ill patient requests physician-assisted dying. Appropriate response: the overwhelming majority of states prohibit most forms of physician-assisted dying. However, physicians may prescribe medically appropriate analgesics, even if these medications potentially shorten the patient's life. Situation: patient is suicidal. Appropriate response: assess the seriousness of the threat. If the patient is actively suicidal with a plan, suggest remaining in the hospital voluntarily. If necessary, the patient may be hospitalized involuntarily. Situation: patient states that you are attractive and asks if you would go on a date. Appropriate response: romantic relationships with patients are never appropriate. Use a chaperone if necessary. Set firm professional boundaries with direct communication. Transition care to another physician if needed. Situation: a woman who had mastectomy says she now feels ugly. Appropriate response: find out why the patient feels this way. Do not offer falsely reassuring statements such as, "You still look good." Situation: patient is angry about the long time spent in the waiting room. Appropriate response: acknowledge the patient's anger, but do not take it personally. Thank the patient for being patient and apologize for any inconvenience. Avoid lengthy explanations of the delay. Situation: patient is upset with treatment received from another physician. Appropriate response: suggest that the patient speak directly to that physician about their concern. If the problem is with a member of the office staff, reassure the patient that you will speak to that person. Challenging patient and ethical scenarios continued. Situation: an invasive test is performed on the wrong patient. Regardless of the outcome, a physician is ethically obligated to inform the patient that a mistake has been made. Situation: a patient requires a treatment not covered by insurance. Discuss all treatment options with patients, even if some are not covered by their insurance companies. Inform the patient of financial assistance programs. Situation: a 7-year-old boy loses a sister to cancer and now feels responsible. At ages 5 to 7, children begin to understand that death is permanent, that all life functions incompletely at death, and that everything that is alive eventually dies. Provide a direct, concrete description of his sister's death. Avoid cliches and euphemisms. Reassure the boy that he is not responsible. Identify and normalize his fears and feelings. Encourage play and healthy coping behaviors, such as remembering her in his own way. Situation: patient is victim of intimate partner violence. Ask if the patient is safe and help devise an emergency plan if there isn't one. Ask direct, open-ended questions about exam findings and summarize the patient's answers back to them. Ask if the patient has any questions. Do not necessarily pressure the patient to leave a partner or disclose the incident to the authorities, unless required by state law. Situation: patient wants to try alternative or holistic medicine. Explore any underlying reasons with the patient in a supportive, non-judgmental manner. Advise the patient of the known benefits and risks of treatment, including adverse effects, contraindications, and medication interactions. Consider referral to an appropriate complementary or alternative medicine provider. Situation: physician colleague presents to work impaired. This presents a potential risk to patient safety. You have an ethical and usually a legal obligation to report impaired colleagues so they can cease patient care and receive appropriate assistance in a timely manner. Seek guidance in reporting, as procedures and applicable law vary by institution and by state. Situation: patient's family insists on maintaining life support after brain death has occurred, citing patient's movements when touched. Gently explain to the family that there is no chance of recovery, and that brain death is equivalent to death. Movement is due to spinal arc reflex and is not voluntary. Bring the case to the appropriate ethics board regarding futility of care and withdrawal of life support. Situation: a pharmaceutical company offers you a sponsorship in exchange for advertising its new drug. Reject this offer. Generally, decline gifts and sponsorships to avoid any conflict of interest. The AMA Code of Ethics does make exceptions for gifts that directly benefit patients. For special funding for medical education of students, residents, and fellows, for grants whose recipients are chosen by independent institutional criteria, and for funds that are distributed without attribution to sponsors. Situation: patient requests a non-emergent procedure that is against your personal or religious beliefs. Provide accurate and unbiased information so patients can make an informed decision. In a neutral, non-judgmental manner, explain to the patient that you do not perform the procedure, but offer to refer them to another physician. Situation: mother and 15-year-old daughter are unresponsive and bleeding heavily, but father refuses transfusion because they are Jehovah's Witnesses. Transfuse the daughter, but do not transfuse the mother. Emergent care can be refused by the healthcare proxy for an adult, particularly when patient preferences are known or reasonably inferred, but not for a minor based solely on faith. Situation: a dependent patient presents with injuries inconsistent with the caretaker's story. Document a detailed history and physical. If possible and appropriate, interview the patient alone. Provide any necessary medical care. If suspicion remains, contact the appropriate agencies or authorities, such as Child or Adult Protective Services, for an evaluation. Inform the caretaker of your obligation to report. Physicians are required by law to report any reasonable suspicion of abuse, neglect, or endangerment. Situation: a pediatrician recommends standard vaccinations for a patient, but the child's parent refuses. Address any concerns the parent has. Explain the risks and benefits of vaccinations and why they are recommended. Do not administer routine vaccinations without the parent's consent. Communicating with patients with disabilities. Patients may identify with either person-first language, such as a person with a disability, or identity-first language, such as a disabled person. Ask patients what terms they use. Under most circumstances, talk directly to the patient. Do not assume that nonverbal patients do not understand. Accompanying caregivers can add information to any discussion as needed. Ask if assistance is desired rather than assuming the patient cannot do something alone. Most people, including people with disabilities, value their independence. For patients with speech difficulties, provide extra time for the interview. If their speech is difficult to understand, consider asking them to write down a few words or rephrase their sentence. Repeat what they said to ensure you understood correctly. For patients with a cognitive impairment, use concrete, specific language. Ask simple, direct questions. Eliminate background noise and distractions. Do not assume the patient can read. Adjust to how the patient understands best, for example, by using hand gestures or asking them to demonstrate tasks. For patients who are deaf or hard of hearing, ask their preferred mode of communication. Use light touch or waving to get their attention. For patients who prefer to speak and lip read, eliminate background noise, face the patient, and do not change your speaking style. Consider using an interpreter when necessary. As with other parts of a medical history, do not bring up a disability if it is not relevant to the visit. For example, a patient in a wheelchair coming in for an ear infection. And do not skip relevant parts of the physical exam, even if the disability makes the exam more challenging. Use of interpreters. Visits with a patient who speaks little English should utilize a professionally trained medical interpreter, unless the physician is conversationally fluent in the patient's preferred language. If an interpreter is unavailable in person, interpretation services may be provided by telephone or video call. If the patient prefers to use a family member, this should be documented in the chart. Do not assume that a patient is a poor English speaker because of their name, skin tone, or accent. Always ask what language the patient prefers. The physician should make eye contact with the patient and speak to them directly, avoiding third-person statements such as, "Tell him." Allow extra time for the interview and ask one question at a time. For in-person spoken language interpretation, the interpreter should ideally be positioned next to or slightly behind the patient. For sign language interpretation, the interpreter should be next to or slightly behind the physician. In cases of emergency, communication should be facilitated by any tools available: friends, family, sketches, interpreter apps, even though these do not represent standard procedure in other circumstances.